My name is Alex Despotes. As mentioned, I'm a fourth-year combined adult and pediatric pulmonary fellow at UNC in North Carolina. And I think this is a really important topic. It's something that I don't think we know a ton about. So I want to give that as a disclaimer, but I think it's something we're all kind of learning about. So I'm excited to have this discussion with you guys today, hear what kind of questions you guys have. This is something that I think we're gonna, like I said, be having to think a lot more about. So I do have grant funding from the CF Foundation, and I am a lung doctor, not a heart doctor. So I feel like I should throw that out there first and foremost. So again, maybe not the best person to be thinking about these things, but I think folks living with CF and the doctors that they see who are mostly lung doctors are going to be trying to sort this out together and likely needing to be pulling more providers from different specialties into this discussion with us. So I'm going to start with a case presentation to kind of lead off our discussion. I think, like many things in medicine, it's really the people we get to take care of that really, or I think should inform some of our research questions, and what the people that we care for, what they think is important, should really kind of guide what we're looking into. And so we'll talk a little bit about a patient that we took care of at UNC. We'll then go over heart disease and specifically atherosclerosis, sort of broadly, give some examples of what atherosclerosis can look like. And then we'll talk about risk factors for heart disease, both in the general population and some of the risk factors that might be changing and becoming more important within CF. We'll then highlight some of the key symptoms of heart disease as well as stroke, just to make people more familiar with things to kind of look out for and pay attention to. And then talk about recommendations for prevention. So as I mentioned, a lot of my interest in this stemmed from taking care of a patient during my first year of fellowship. I was the fellow on call, and I received a call from a young woman in her early 30s with CF, followed at our center. She had a history of CF-related diabetes. She had pretty significant lung disease, but had been doing better after being on a highly effective modulator for about a year at that time. And she was calling because of shortness of breath and chest pain that she'd had for the last 2 days. And I should mention this was in December 2020, so it was like the height of the COVID pandemic. It was also over the holidays. And so again, this was overnight. So we kind of talked through things. There wasn't really a good way to kind of get her into clinic to evaluate things. We just sort of talked on the phone at that time, and she really hadn't been able to eat or drink much the last couple of days. She'd had some nausea. She was short of breath, but hadn't had really a change in her cough or change in mucus production. And she hadn't had fevers or any known COVID exposures. So I was pretty worried, although I didn't know exactly what was going on. It was one of those things that I knew I wasn't going to be able to sort out over the phone with her. In particular, I was worried, gosh, could this be a CF exacerbation? Could this be COVID? I also was worried about a pneumothorax or a collapsed lung, just given the chest pain. And then also thinking about causes of chest pain that in my mind at least could go along with CF, was thinking about like a big mucus plug. She had a history of acid reflux, but she already tried some antacids at home and they hadn't really helped her symptoms, but certainly kind of bad reflux can cause chest pain symptoms, or kind of a bad pulled muscle from either coughing or doing something else active. But I told her that I was pretty worried that we needed to have her be evaluated in person. And unfortunately, that meant going to the emergency room. And so that's where she went for further evaluation. And so this was her EKG. And you can see in this area that she's got some changes where parts of her electrical activity are sort of abnormal. This is what we call ST elevations. It's just describing the pattern of the electrical activity. Certain segments of it should be flat, but in hers, they're kind of raised or elevated here. And so this was just showing that part of her heart seemed to be under stress. And similarly, the emergency room that has really good protocols for evaluating things like chest pain had also done some lab work on her, and she had very abnormal labs with relation to her heart. These are markers of kind of heart stress or strain. So she had a very elevated troponin, and then her pro-BNP, which can be a marker of stress on the heart in the sense of like heart failure, was also very abnormal. And so when I was looking at her workup as things were kind of coming back from the emergency room, I was really surprised. It was not at all on my radar to be thinking about a heart attack. And in this case, a very severe heart attack, what we call a STEMI or ST elevation myocardial infarction. But again, this is why the emergency room has protocols for getting an EKG and doing this type of assessment for really classic symptoms like chest pain. And so she went to the cardiac cath lab, and they found a 100% blockage in one of her main coronary arteries, which is called the left anterior descending artery. And they were able to place some stents in those blood vessels and fortunately restore blood flow to her heart muscle. And overall, she did really well. But again, I was left after taking care of her sort of startled, like, oh my gosh, is this something that I should have been thinking about in CF? Is this something that happens? Again, I was just a first-year fellow, but when I went back with my kind of supervising docs who have been, taking care of people with CF for many years, they were like, no, that's really, odd. We don't really see this in CF. And so that's really, again, what caught my interest. And we'll talk a little bit more kind of about what we've done at UNC in response to all this. But fortunately, she's done really well. So this brings me to what is atherosclerotic cardiovascular disease. Are you guys seeing a weird bar on your screen with the presentation? No? Okay, good. Just on my view. So what is atherosclerotic cardiovascular disease, or what this patient was experiencing? Well, this is a list of different types of atherosclerotic cardiovascular disease, but what the issue is in atherosclerosis is narrowing of the blood vessels throughout the body, and those vessel walls become weaker and less flexible. And as a result, it's harder to get blood flow through to critical organs, including the heart and the brain. And there's lots of things that can cause blood vessel narrowing, but in atherosclerosis, that narrowing is due to the buildup of what we call plaque, which is kind of a fatty deposit that builds up. And I'll show some diagrams in a minute here, but this process occurs over time, and some of the risk factors we'll talk about kind of contribute to why this develops. And so this narrowing of the blood vessels due to this plaque can then lead to decreased blood flow, and then as a result, decreased oxygen to critical organs. So when this takes place in the heart, it's called coronary heart disease or coronary artery disease, and this leads to things like heart attacks. When there's more of a complete blockage and that heart muscle starts to be under stress and even starts to die, sort of like what was happening in our patient, or if it's not a complete blockage and symptoms are only really happening when someone's exercising or doing certain activities when they need more blood flow but can't quite get enough blood flow during those times, that's called angina, and you get sort of chest pain that comes and goes. And then we'll talk more about strokes in a minute, but for our circulation to our brain, when this occurs, it leads to strokes or transient ischemic attacks, sort of mini strokes. You might have heard them called that. And then we won't go into detail about peripheral artery disease or atherosclerosis and like kind of the main big blood vessels in the heart, like the aorta, but this just kind of list shows that this process is happening in the arteries, can happen in the arteries throughout the body with kind of different outcomes. So as far as what's happening in a heart attack when thinking about atherosclerosis, as we mentioned for this patient, the coronary arteries are what supply the blood and the oxygen to the muscles of the heart. And so when atherosclerosis builds up in the coronary artery walls, you can see that then there's this narrowing that occurs. And this is usually a process that takes a long time to develop for this kind of plaque to build up. And so that's one of the reasons why heart disease like this and atherosclerosis become more common as we age. There's been more time for these processes to occur. And sometimes you can get more kind of sudden onset changes in blood flow if the plaque that's been building up becomes unstable. Sometimes there can be little clots that form along that plaque wall, and so you might get a more sudden change in that blood flow to your heart rather than just kind of progressive narrowing. And so if it's a really dramatic narrowing in those blood vessels, like our patient had, where she had a 100% blockage when they went to the cath lab, that's really what can cause, that's essentially a heart attack. And that's what caused the heart muscle to be under stress, not get enough oxygen. And ultimately, if not opened back up, that heart muscle can die and that function won't be the same in the heart. And then just briefly for kind of illustration, same idea as far as what's happening when people have a stroke is, again, some of the big blood vessels that come up from the neck that supply the brain, the carotid arteries, they can also build up this plaque that causes narrowing. So that in of itself can sometimes cause symptoms, but usually what's happening in a stroke is plaque from somewhere else or a little clot from somewhere else is then breaking off and going to the smaller blood vessels to parts of the brain or a part of the brain. And the part of the brain that's then no longer getting good blood flow, that's the part that's having the stroke. And so that's why you see different symptoms from strokes depending on which part of the brain is affected, how large of a territory of the brain is affected. And so it's really important to be aware about atherosclerosis and in particular cardiovascular disease from atherosclerosis because it's a leading cause of death in the US. And you can see here from recent data through the CDC that it's the highest cause of death in recent years. This is just kind of showing 2021 and 2022, but it's been the highest cause for quite some time. So you can see more than all cancer-related deaths. This was, again, data that included some of the COVID pandemic mortality. And then you also see that stroke is pretty high up on this list too. So atherosclerosis is a really big deal that causes a lot of issues. So we're here to talk about heart disease and CF. And as I mentioned, as a fellow, I was told that, well, heart disease is really rare in CF. This is not something we've really had to worry about. In fact, there was some thought that having CF might actually be protective against developing heart disease. But again, I think we're kind of shifting away from that idea. But that was thought to maybe related to the fact that people with CF have usually had very low levels of cholesterol. And we'll talk about that, cholesterol being a risk factor for heart disease. Additionally, smoking rates are very low among folks with CF when you look at the registry data, and smoking is a big risk factor. And additionally, usually body weight has been very low in CF, and we think of obesity being a major risk factor for heart disease. So for several reasons, heart disease was thought to be rare, and we really didn't see it very often. But I think one of the biggest things to point out is we've seen such a dramatic improvement in life expectancy. You know, we really weren't comparing kind of what the rates of heart disease were in similar ages of people, since heart disease becomes more common with aging. I will acknowledge that there have been some issues with the heart related to CF separate from atherosclerosis, and this is due more to really significant lung disease. And so really bad lung disease from lots of different causes, including sort of really severe CF can lead to low oxygen levels throughout the body. And the lungs try to regulate kind of the amount of blood flow going to areas to pick up oxygen. So if there's not a lot of oxygen in an area, the lung will kind of tighten the blood vessels or constrict the blood vessels in that area to try to send blood to other parts of the lung so it can pick up more oxygen there. But if there's a lot of disease in the lungs, that's kind of an issue throughout the lungs. So you've got all these blood vessels in the lungs that are narrowed. And that means then that the heart, and specifically the right side of the heart that pumps to the lungs, is having to squeeze against these more narrowed blood vessels. And that's a lot more work on the heart. And so as a result of kind of higher blood pressure in those pulmonary vessels, or what we call pulmonary hypertension, we can see that right heart failure can develop when you have significant lung disease. And so right heart failure, or what we would call cor pulmonale, was seen in CF, but that was because of really severe respiratory disease. So heart disease was not totally absent from CF, but is a little bit different than the kind of atherosclerosis type of heart disease that we're talking about, maybe becoming more of a concern now. And additionally, there's also been arrhythmias or abnormal heart rhythms described in CF, either due to kind of this type of heart failure that can develop as that heart muscle kind of gets stretched and thinned out, or as a result from different medication therapies that can predispose people to abnormal heart rhythms. But this coronary artery disease related to atherosclerosis was pretty uncommon, as I mentioned. This was a study done of patients from 1996 to 2016, where they were looking at folks with CF who were undergoing transplant evaluation. And one of the common things that is done as part of transplant evaluation is to look for coronary artery disease. So these people underwent cardiac catheterizations to look for blockages in those coronary arteries, like our patient had at the beginning of the presentation. And in the 16 patients that they looked at, there were no signs of blockages or atherosclerosis. And these were all in folks around or older than 40, so slightly older group, but we really didn't see atherosclerosis there. But you'll notice the year, this was up until 2016. And again, we know that a lot has changed in CF since then. So that's kind of the history of what we've thought about heart disease in CF. But how is that changing now? And I will say the short answer is we don't know entirely, but I think we're moving away from, although there's usually or previously been some protective things related to CF, like the low levels of cholesterol, low body weights, there's other factors that we'll talk about that might actually change risk for heart disease. So chronic inflammation is a big one that we'll talk about, and that can contribute to this kind of plaque development. Folks with CF-related diabetes might have some similar risk factors to folks with other types of diabetes. We'll talk a little bit more about the kind of dietary recommendations in CF that have usually included high fat intake, and how does that contribute to atherosclerosis development? And is there anything to think about with the CFTR protein itself related to blood vessel walls? With that, we'll kind of move into talking about risk factors, both in the general population, where we have the most data to kind of say, if you have these certain characteristics, you have a higher risk of heart disease. And then what similar risk factors might be present in CF, and maybe some differences. So in the general population, this is a list of things that put people at higher risk for heart disease. One of the biggest ones is family history. So if you have lots of folks in your family that have had problems like heart attacks or stroke, or things like high blood pressure and high cholesterol run in your family, in the general population, that's something we think about. Okay, that might mean that you're at risk for those risk factors and therefore at risk for heart disease. The biggest specific risk factor is if any of your family members had an early heart attack or early heart disease, that might be a more significant risk factor. So for your male relatives, so like your dad or your brother or your uncles or grandfather, if any of them had a heart attack when they were younger than 55, that would be an increased risk. And then for your women relatives, if they were younger than 65 when they had a heart attack, that would maybe say that you're at increased risk. High cholesterol is a big one. These are some of the specific numbers, but I will say this is frequently taken in the context with other risk factors. And so you might see that people get started on cholesterol medicines at lower levels of cholesterol, not so much because of the number itself, but to try to further reduce the overall risk. So I think the absolute number is not the most important thing to focus on. And then there's this entity called metabolic syndrome. where if people have kind of a few of these findings together, we think of them as being at higher risk for heart disease. And so we know that being overweight can put you at risk for heart disease, but specifically if you carry more weight around your waist, that's thought to be higher risk, along with elevated triglycerides, or even having a low level of what we call HDL, or the good cholesterol, it's sometimes called. So it's, again, not the absolute number of cholesterol, it's sometimes the ratio of the different parts of the lipid panel that can influence risk. And then high blood pressure and diabetes. So having a couple of these things together in the metabolic syndrome puts people at higher risk for heart disease in the general population. And then things like kidney disease, because our kidneys are important for regulating our blood pressure. And then chronic inflammatory conditions like rheumatoid arthritis and lupus. Folks with those conditions have had been shown to have higher risk of heart disease. And then again, the biggest risk factor that we can't really modify is aging. We know that the likelihood of having heart attacks and strokes is much more common as you get older. So that's kind of broad strokes, recognized risk factors in the general population. What about in CF? So again, aging, I think this is a thing that we're excited about, but it's a big risk factor. I think overall, just living into the decades where these conditions become more common would be considered a risk factor. Again, you don't want the reverse to be happening, but it's important to acknowledge this is just going to be a risk factor that more and more folks with CF will have. One of the biggest ones that people have been talking about is rates of obesity. And this is true in the general population where this has been on the rise, as well as in CF. And this has been going on even prior to widespread modulator use. You can see on this graph here that rates have been going up for obesity, both in kids and adults, as well as the general population and those with CF since kind of the mid-90s. And we know that many people who have experienced more weight gain after starting modulators. While there's some good things about that, because we know that low body weight, if it was too low, that was associated with lower lung function. And that's why, the dietary intake has been such an important focus of CF care, and why it's such a big focus in pediatric centers. We want kids to be growing well because we think that's important for their lung health and growth. We're now having to kind of rethink some of that. We think that there's likely improved fat absorption from the diet for people on modulators. And then sort of separate from that, when your body isn't having to deal with so many respiratory issues and your respiratory health is improved, you're not having to spend calories, as many calories just to breathe and to fight infection. So rather than kind of burning through those calories, your body is then, anything extra is kind of being stored as fat. So again, the CF legacy diet was this kind of high fat, high calorie diet. And I think a lot of folks have been wondering if we need to change our thinking around some of that or modify it depending on growth and other parameters. And then both in the general population and within CF, folks have noted that obesity seems to predispose people to insulin resistance, higher blood pressures, and then higher cholesterol, which we know are other risk factors for heart disease, like we just discussed. Blood pressure is, again, another risk factor that, as we just mentioned, is associated with obesity. This is kind of a chart showing sort of what normal blood pressures are, and then kind of the different gradations of severity of blood pressure elevations. We typically need to see that blood pressures, elevated on multiple occasions, not just a one-off once in clinic. This is something that we should be checking at most of our clinic visits anyways, to be able to keep an eye on. But what are some specific things, thinking about CF care, that could influence blood pressure? Well, salt intake is another big nutritional recommendation that we encourage from a very early age. parents are taught to kind of how to incorporate salt when feeding their babies with CF, and salting food is very liberally recommended. But we know that high salt in dietary intake in the general population can raise blood pressure. So what is this going to mean for folks with CF? And then if folks develop kidney disease, that can lead to high blood pressure. The kidneys, as we mentioned, kind of regulate blood pressure. And so if they're not working as well, that blood pressure control gets more difficult. And so why would folks with CF potentially develop kidney problems? Some of the biggest reasons for that might be exposure to medications they've needed over the years to treat pulmonary exacerbation. So antibiotics like aminoglycosides, such as tobramycin and amikacin, those at high levels and with kind of repeated exposure could put stress on the kidneys that over time could cause or contribute to chronic kidney disease. And similarly, if folks need to undergo a solid organ transplant, like a lung transplant or a liver transplant, some of the medicines used to help prevent organ rejection can be pretty tough on the kidneys, like tacrolimus. So a couple different reasons that could contribute to injury to the kidneys over time in CF. And then interestingly, there have been small reports of blood pressure going up a little bit when people have been started on modulators. Usually only by a few points, so not necessarily causing high blood pressure. But there have been some case reports where it has been enough where someone's had to be on a modulator as well as a blood pressure medicine because their blood pressure has been higher. So again, with modulators kind of turning on that CFTR activity throughout the body, that CFTR channel is kind of influencing our balance of salt. And so again, we talked about salt being something that can influence our blood pressure. What about CF-related diabetes? We mentioned that diabetes in the general population is a risk factor for cardiovascular disease. So we know that CF-related diabetes is its own entity. It's not type 1 diabetes, it's not type 2 diabetes, but it does share some features with those conditions, both in the sense that there's relative insulin deficiency, but also some insulin resistance, like in type 2, especially during times of higher inflammation, like during a pulmonary exacerbation, blood sugars can be harder to control. So we know that there are some vascular or blood vessel complications that can develop over time with CF-related diabetes, like we see in type 1 and type 2 diabetes. But fortunately, these take a long time to develop, usually over 10 years, and having good blood sugar control can really help minimize these complications. But some of those vascular complications can include kidney disease. So again, going back to could this somehow feed into other risk factors? And then also eye disease. Fortunately, we really haven't seen strokes and other types of larger blood vessel complications from CF-related diabetes, like we see with type 1 and type 2 diabetes. But I think we really don't know how CF-related diabetes might change with modulators. We know that CF-related diabetes is more common in adults with CF, and so we think it is one of those things that might develop with aging. But we're not sure if, starting on a modulator, if that will be able to kind of prevent development of CF-related diabetes if started early enough. So far, not a lot of folks have really been able to come off of their diabetes medicines after being on a modulator. We also know that with folks just living longer, if you're living longer with CF-related diabetes, will we see more complications over subsequent decades? So I would say we don't really know how CF-related diabetes fits in, but I think there could be some ways it could influence cardiovascular risk. And then what about inflammation? We mentioned that other inflammatory conditions like rheumatoid arthritis and lupus, for those people, that's an increased risk factor for heart disease. So we know that inflammation can be high in CF. There are a few groups that have looked at kind of blood vessel stiffness in folks with CF. And what they found is that there is some increased stiffness, which we worry could be an early sign of atherosclerosis. And that was especially true for folks that had higher levels of inflammation, as well as certain lung infections like Pseudomonas and Stenotrophomonas. There was a recent study looking at people within a European CF registry and kind of comparing those folks with another major registry of the general population, and kind of matching sort of same age and sex within those registries, and then seeing what the risk was for major cardiac events. And within CF, they found that folks that had who were older, as we aren't surprised about, and then who had typical risk factors like hypertension and diabetes, had a higher risk of having some of those major adverse cardiac events. But interestingly, folks with other factors that are less clearly heart risk factors also seem to be at higher risk, and that was being on more days of IV antibiotics, as well as having lower lung function. So again, those things in and of themselves don't seem like they should be heart risk factors, but when you think about it from the framework of inflammation, were those folks on more days of antibiotics because they were dealing with bad infections, and was their lung function lower because of pulmonary exacerbations? Those then make you think about that inflammation component. So similar to what was seen with kind of other inflammatory conditions, folks with CF had sort of higher rates or higher proportion of major adverse cardiac events when they looked at the CF registry compared with the general population, and similar levels when they looked specifically at folks with HIV, lupus, and rheumatoid arthritis. So I think this study kind of shows that we should think about the typical risk factors for heart disease within CF, but also thinking about inflammation as something that can be specific to CF as an important risk factor. But I think when thinking about inflammation, this is maybe an area where modulators and future CF treatments might actually really be able to help reduce risk of heart disease. I feel like a lot of what I've said so far is, oh, a lot of these things might be increasing, but I think we know that with modulators, inflammation ends up becoming much lower. And so maybe additional treatments plus modulators might help bring some of the risk from inflammation back down. So I think this is an interesting thing to think about in CF that may not get mentioned as much when learning about heart disease for the general population, that I think is important to think about in CF. And then we talked about cholesterol, that it was usually really low in CF. I think this is an area where already we've seen changes coming out in the medical literature with several groups, including our group at UNC, reporting increases in total cholesterol and low density lipoprotein, LDL, or what's sometimes considered bad cholesterol, after people are started on highly effective modulators. And when we looked at this at our center, we found that the folks that had the largest rise in their cholesterol parameters after being started on a modulator were those that had a family history of heart disease. And so it kind of goes back to maybe our genetics outside of CF start to take on their more usual role, with the things that run in your family are very relevant to what you might be predisposed to. And so I don't know if this is something everyone's really thought about talking with their family members about. We realized at our center that we weren't great at asking our patients with CF about this, because we usually weren't worried about heart disease. So this is an area where we've really changed our practices to try to be thoughtful about asking what else runs in your family with aging. And so I would be asking your family members about cholesterol, again, especially early heart disease, and then talking with your doctors about that too. And then this is actually probably something I should have listed on the risk factors in the general population, is Mood disorders, I think there's a little bit less evidence for this overall, so it didn't make that slide, but I think it's still important to consider because it's again something that if someone's experiencing chronically high levels of stress or has untreated anxiety or depression, we know that those states can put stress on the blood vessels and the heart. And so those are things that we could improve with treatment. So I think it's important to acknowledge that maybe these aren't the strongest risk factors for heart disease, but addressing them can still be important in protecting your cardiovascular outcomes. And we know that just like in the general population, we've seen that mental health challenges are not uncommon within CF. And we also know with going through the pandemic these last few years, it's been a really stressful time. There are also some folks that experience worsening mental health or even new anxiety or depression after starting modulators that's prevented them from being able to remain on those medications. So again, in thinking about CF, I think just one of the other things for us to try to make sure we're assessing, and then also if it's present, try to help address to see if we could kind of help reduce risks. And then what about CFTR modulators themselves? Are people worried about those changing risk for heart disease? I think we really don't know yet. I hope I've shown that there could be a lot of ways that some of these risk factors change and maybe already are changing. And some of that might be due to modulators. There might also be ways that modulators might help reduce risk in other ways, like we talked about with inflammation. So again, I think it's likely not just the modulator in isolation. It's more how we kind of think about all these risk factors together, because certainly they've brought a lot of great changes. I think it's just in the context of those, we've got to make sure we're thinking about all the different downstream effects. I did want to spend just a few minutes highlighting some specific risk factors that are slightly different for women in the general population. And I will say most of the major studies of heart disease in the general population, kind of going decades back, were mostly focused on men. And so this has been kind of an evolving area. And for women, kind of hormonal status plays a bigger role since that changes so much throughout a woman's lifespan. So we mentioned some of these autoimmune diseases already. Women do frequently tend to be at higher risk for autoimmune diseases. So those are commonly more risk factors for women for heart disease. Early menopause, because of the hormonal changes, has been associated with higher risk of cardiovascular disease. And even looking back, folks that have had sort of pregnancy complications such as gestational diabetes or preeclampsia down the road might be at higher risk for heart disease. Both breast cancer and some of the treatments for breast cancer can put people at risk for heart disease. But sort of protectively, breastfeeding and pumping for lactation has actually been shown to reduce the risk of developing heart disease. Briefly, just to mention, while we're talking about hormones and heart risk, some people might be wondering about, well, what about taking hormone-containing birth control? It does have some effects on your cardiovascular system, but most people can tolerate it okay. It might raise blood pressure a little bit. It definitely does have the risk for increasing blood clots. Again, most people tolerate it just fine, but important to know if you're already at higher risk for blood clots. And a lot of what we know about risk of cardiovascular disease and these types of things with birth control comes from when we used to use much higher doses of estrogen. And so the dosages we use now in contraceptives are typically much lower, but just kind of important to recognize. So that does mean there are certain folks that maybe should avoid hormonal contraception. So being older, especially if you smoke, or if you have multiple risk factors for heart disease, if you already have high blood pressure or have had a blood clot in the past, if you already have heart disease or stroke, certain other types of structural heart disease are also recommended that you avoid these types of medications. Breast cancer we mentioned already, certain liver conditions, and then migraines with aura. There is a good reference if you're not sure what option could be good for you for kind of birth control options through the CDC. There's this giant chart, and it just kind of shows you different types of contraception and whether it's totally safe or benefits usually outweigh risks, or if it's definitely you shouldn't be using it. You'll see that pretty much all of them are okay to use in CF, but you'll see that there's some recommendations against using the hormone-containing contraceptive pills for like blood clots, breast cancer, and those sorts of things like we discussed. And this is only going through part of the alphabet. It's a huge chart, but just know that it's out there if you're ever not sure. And then just briefly, I mentioned menopause. This is another area within aging that I think we still have a lot to learn within CF. So menopause is essentially sort of the natural biological process that marks the end of a woman's menstrual cycles and reproductive years. It's diagnosed after a woman hasn't had a period for 12 months, and usually happens between ages 45 and 55, but can happen earlier. If it happens before age 40, that's sort of premature menopause. And for some people, it happens later. But this is a big change in terms of sort of hormone exposure for women. And so this is a time period where cardiovascular risk also changes. As estrogen levels fall, we have more predominance of some of our more kind of male hormones imbalance, and this kind of changes the cardiovascular risk because estrogen itself is thought to be somewhat protective in the sense that it typically keeps your HDL or good cholesterol at a higher level. And earlier in life, it helps kind of keep your blood vessels more flexible and able to dilate to deliver good blood flow. And so after menopause, as estrogen levels drop, those blood vessels are a little bit more stiff. You get changes in blood pressure, changes in cholesterol levels. And so cardiovascular risk can really change. That's actually one of the reasons why folks were interested in studying hormone replacement therapy to see if we could reduce risk of heart disease for postmenopausal women by giving them extra estrogen. And that's actually where we learned that replacing it at this stage actually can increase risk of heart disease. So it's a little bit counterintuitive. People really thought that they would be able to kind of help reduce risk, but this appears to be sort of what needs to happen naturally. There are reasons to be prescribed hormone replacement therapy if people are having significant symptoms from their menopause itself, but it's not recommended to give estrogen to reduce heart disease for a lot of the reasons we just talked about. We, again, don't really know a lot about menopause in women with CF. There was one survey that was done, and typical menopause symptoms were common in women with CF. So things like sleep problems, some of the joint stiffness, and hot flashes and night sweats. And interestingly, we know that changes in hormone levels also influence kind of CF symptoms, both kind of going through puberty, and then as well as kind of a change in symptoms when women were going through menopause and then after menopause. So I think this is, again, an area where we're going to need to do a lot more learning to kind of help folks navigate through this transition. As far as symptoms of heart disease, we talked a little bit about someone who came in with a heart attack, and she actually had pretty classic symptoms. It was just someone we weren't expecting to have a heart attack, but having chest discomfort. It can even be more of a pressure or squeezing. It might come and go after a few minutes. The pain can kind of radiate elsewhere, either up to the jaw or down the arms or to the back. You might hear people report that. And then shortness of breath is pretty common as well. Some people get other symptoms like breaking out into a sweat, feeling nauseated, or feeling dizzy or lightheaded. So some of the symptoms can be a little bit more nonspecific, but chest discomfort is the most common and sort of typical symptom. Symptoms can vary from person to person, though, and although in women the most common heart attack symptom is still chest pain or discomfort, women may be more likely to experience other symptoms that people might not immediately jump to heart attack with, such as the shortness of breath or some of the dizziness and lightheadedness. And then folks that have long-standing diabetes, and again, this is coming from not CF-related diabetes, I should say, but in other types of diabetes, folks may have more of a silent heart attack where due to neuropathy or decreased sensation from damage to the nerves over time from high blood sugars, the symptoms of that kind of heart under stress due to reduced blood flow may not really present as chest pain, but the person's still having significant damage. So again, they might have more vague, non-specific symptoms and might not even have chest pain. So it can be a little bit tricky. And then just for recognition, one of the other major common causes of death related to atherosclerosis is stroke. And so what are the main warning signs related to strokes? There's this acronym that's used to help remind people of the symptoms and also to remind people if you see these symptoms, the sooner you can get somebody evaluated and treated for a stroke, the better. They can have better outcomes if treated quickly. So F stands for kind of facial drooping. So asking someone to smile and see if their smile isn't even on both sides, or they might have facial numbness. Arm weakness, so having someone hold out their arms in front and see if one arm kind of slowly drifts down because it's gotten weaker. Speech difficulty, whether they're slurring their words or having a hard time finding their words. And the T just stands for time to call 911 because the timing of getting someone evaluated as soon as you notice symptoms is so important. There are certain treatments for strokes that are only available if done within a certain amount of time after symptom onset. Other symptoms of stroke can include numbness, one side of the face like we talked about, or arm or leg, especially if it's only on one side of the body. Confusion, whether they're having a hard time speaking or understanding speech, difficulty seeing in one or both eyes, difficulty walking or feeling dizzy or uncoordinated, and then a severe headache without other clear causes should also be a concerning sign. So when in doubt, if you're experiencing these symptoms or you notice these symptoms or someone is telling you these symptoms, even if you're not 100% sure, the safest thing to do is go ahead and call 911 to get them evaluated quickly. Again, for our patient, I think she had such a good outcome because the emergency room immediately kind of assessed her for a heart attack when she mentioned that she had chest pain, and they got her quickly to get to the therapy with the stents that she needed. So how do we reduce our risk for heart disease? How can we prevent some of these issues from arising? And again, this all comes from kind of the general population. So there might be ways that we need to think about this differently within CF. So both diet and exercise are kind of some of the mainstays for trying to protect yourself against heart disease in the general population. And I think this all very much applies within CF, especially with some of the trends that we're seeing in terms of obesity being on the rise. So it should be a balanced diet with healthy protein sources, avoidance of more processed foods. And you'll see here the recommendation is to cut down on salt. And again, within CF, that goes against a lot of what folks have been told from a very early age. So again, I think this is going to be something we have to really think about together, the providers and patients and other specialists too. What's the right way to go about this? And then lower fat, less added sugars, especially if you have blood sugar control issues. And then limiting alcohol is another one. Like lowering salt, alcohol can really raise blood pressure. And then exercise, this has always been something important in CF care. We think of it as a great form of airway clearance. And so hopefully this is something that folks with CF are used to incorporating into their routine. And the good news is this is also great for your heart. So the recommendation from the American Heart Association is to try to get at least 150 minutes a week of either of moderate intensity activity or 75 minutes per week of more vigorous activity. And this doesn't have to be in one sitting. In fact, if you can do it in a couple of smaller chunks throughout the week where it becomes part of your routine, that's great. I think one of the biggest challenges is many people in their day-to-day life working, they're frequently at the desk seated. And so this is something simple, or even just getting up, walking around throughout the day, or the annoying Apple Watch telling you to stand up a few times throughout the day, actually can be really important. So I think we all have a much more sedentary lifestyle, just the way the world works now. So trying to be conscious about moving around a little bit more. And again, this isn't something you have to go out and run a marathon right away. This is slowly building up intensity, and something to incorporate as part of your routine. These are some recommendations that the American Heart Association had. The type of exercise really doesn't matter, as long as you're getting your heart rate up and doing it throughout the week. Find ways to make it more fun. If you enjoy doing a group exercise class, if you enjoy listening to certain music, it doesn't have to be just you running on a treadmill. It can be really whatever you find more enjoyable, as long as it's keeping you moving and getting your heart rate up. Making sure you've got the right equipment, so the right footwear, making sure you're stretching, again, talking with your doctor if you're someone who's maybe not been doing a lot of exercise, talking with them about, anything I need to think about as I'm getting started doing this. If you've got prior injuries, ways to kind of find types of exercise that are safe and comfortable for you to do. And then, as we already mentioned, break up your exercise throughout the week, and you can even break it up throughout the day. That helps you with that kind of sedentary lifestyle situation that we all deal with. And then just kind of building it in and giving it time to become more part of your routine. There are lots of great resources out there. Again, not a cardiologist, so there are lots of good sources from cardiologists and experts. Again, they probably won't mention CF on these websites, but they're really good resources for kind of thinking about how to make other changes if you have other questions. And then there's so much that we still don't know within CF. So I hope I've tried to kind of convey where we're watching something that's changing, but we're not really sure what this is going to mean for folks with CF. So like I mentioned, what adjustments to the CF diet are we going to need to make, not just for folks right now, but especially thinking about kind of early childhood eating habits as part of the larger sort of global childhood obesity epidemic. So many of our dietary patterns are formed at an early age. So again, what focus should be on the CF diet? How should the CF diet change, especially early on, to really set people up for success for healthy eating for life? One of my big interests has been in these cholesterol changes. Again, it was something that we weren't really checking routinely at UNC. I don't know how many folks on here have had their cholesterol screened routinely. Again, we usually weren't worried about it. So how often should we be doing this in CF? We don't have a lot of guidance on when to do this. And if we're seeing higher levels, when do we start treatments for cholesterol? And what medicines out of the available medicines are the best medicines for treating cholesterol and high blood pressure for someone with CF? As far as, thinking about interactions with other medications based on our knowledge of the physiology of CF. These are all things we don't know yet. And really, we just don't know yet what cardiovascular disease might look like now with folks living into older and older decades. So there's so much we don't know. Hopefully we're all able to kind of partner together, because I think it's going to be kind of observations that you all make, discussions with your providers, pulling providers outside of the pulmonary team with the endocrinologists that are managing CF-related diabetes, primary care doctors, maybe heart doctors, maybe nephrologists. I think this is going to be a big project for us to all learn more about. On that note, I want to make sure we have time for questions and discussion, but having a primary care provider in addition to your CF lung doctor is really important. Your CF lung doctor might not be as familiar with all of the age recommended screenings. And so you want your primary care doctor to be thinking about, okay, you're 45, anything else we need to think about checking you for? Okay, you're 55, anything else we need to think about? Again, I think it's really going to be a team effort to make sure we're not missing anything while we're all learning together. And then these are kind of the cholesterol screening recommendations in the general population. Doing it twice in childhood to kind of screen for early inherited conditions of abnormal cholesterol. And then in adulthood, the recommendations are a little bit variable depending on which organization you look at, but usually repeating screening every couple of years depending on other risk factors. And again, in CF, we know that we should be screening those with CF-related diabetes based on expert opinion. In folks that have other risk factors. But beyond that, we really don't know right now. So at the very least, probably at least sticking with the general population recommendations. But I think this is an area where hopefully we'll be able to come up with more guidance in the coming years. And our patient ultimately, she did very well, as I mentioned. When we looked back, kind of what risk factors did she have for this happening? I mentioned that she had been on ETI and her lung function had really improved. But during that time, she had gone from being underweight, which she had always struggled with low weight, to being in the normal range of BMI, but had gained about 15 kilograms. So again, overall, we thought this was a good thing from a lung perspective that she was able to maintain that weight, but maybe not a great thing depending on the body composition. Again, she had really hard to control diabetes and had had it for since her teens. And so was that a contributing factor? And then she was someone who did have a family history of high cholesterol. And when her endocrinologist had been monitoring her cholesterol, she had had a significant rise in her total cholesterol and LDL after she had started on elexacaftor, tezacaftor, ivacaftor. So again, all things that we've now tried to be more aware of at UNC. She had 2 stents placed in her heart and she had good blood flow. She was started on blood thinners to help protect those stents, make sure they were staying nice and open. And she went home after a couple of days and she's done great since. In follow-up with the heart doctor, she's had complete return to normal heart function. So again, she's done well. And I think we all learned a lot, and I think it's improved the way that we're thinking about patient care at our center. So with that, I would love to kind of hear what thoughts you guys have, answer questions. I might stop screen sharing so I can better see the chat if there's anything in there. But again, thank you guys for the opportunity to discuss this with you all today. I hope I've shown that I do not have all the answers. I have more questions than answers, but I think it's a really important topic. So thanks for letting me talk more about it.